Good afternoon, everyone. I'm Neil Love from Research to Practice, and welcome to Exploring Current Considerations and Promising Investigational Approaches for Patients with Myelodysplastic Syndromes. We have a great faculty today for this program. Dr. Guillermo Garcia-Manero from MD Anderson in Houston, Dr. Gail Roboz from the Weill Cornell Medical College in New York, and Dr. David Sallman from the Moffitt Cancer Center in Tampa. A lot going on. I don't know how we're even going to do this in an hour, but here's our global plan. I want to chat just a little bit about a macro view of MDS and what's going on now, where you think things heading, and then we'll get into current management, some of the new developments in the field, including some of the new agents, which I found really interesting. We're really going to focus on cases from the practice of the faculty. We actually have 9 cases that we're going to at least briefly comment on to really try to bring this into a more practical clinical environment. So we're going to start out just with a little bit of a prologue before we sort of dive into the specifics about clinical management and where we are. But it's just interesting to look at the field and how it's evolved over the last few years. I thought we could just start out. David, you put together sort of this hypothetical patient. I think it really is a good way to kind of get started in terms of really the new view of this disease. Can you talk a little bit about sort of this clinical scenario, David?
Yeah, sure. So this is a 60-year-old patient, and I think really the key of this one is the molecular abnormalities in this patient. So she has a very high-risk complex karyotype, monosomal karyotype, numerous abnormalities with 12% blasts. And then I think based on that, you can predict that this patient may very likely have a p53 mutation. I think the really key part of this is that, all high-risk MDS patients are not created equal. We really need to think strongly about unique investigational approaches and trials for the p53 group, because if you just do the standard of care, these patients have very poor outcomes, median survival of 6 to 12 months no matter what you do. And so I think being able to identify these patients is relevant. So I think one key point is you have time to wait for NGS, but even in the time while you're waiting for NGS, there's a couple of ways to rapidly identify these patients. One would be if you have a FISH panel that turns around with 5, 7, 17 abnormalities, and you have 5 with either of those, you could predict with almost 100% certainty. If you see increased ring sideroblasts, which I know we think of as a low-risk part of the disease, but in the setting of excess blasts, that's highly concordant. And there are a couple of other ways to do that, particularly, let's say, the history of a patient if they're therapy-related. So it's really just to say this is a bad group. This happens actually in up to 20% of our patients and higher in therapy-related, and we really need to highly think about clinical trial for this group of patients.
So, Gail, as you know, our primary target audience is the general medical oncologists. They don't just treat AML and MDS. They're treating bladder cancer, breast cancer, CLL, et cetera. So we're looking at this from a global perspective. From my global perspective, I feel like we're kind of moving from looking at cytopenias and number of blasts into somatic mutations. I know that's kind of simple, but from a practical point of view, it kind of means you need to know their mutation status before you figure out what you're going to do. Any thoughts, Gail?
The number one message is, guess what? It's market to do next generation sequencing in MDS. And that's kind of not obvious to everybody yet, because there was a lot of discussion of what's the point? There are costs associated with sequencing. Are we really going to be changing management? And the short answer is yes. And this is actually going to be highlighted in some of the discussion that we have planned about novel classifications and prognostic schemes for MDS, which actually are including now mutational data. So if you go to the online calculator for the IPSS-M, which especially if you live in New York, your patients are going to do that before they get to the office, they want to plug in their information. So you've got the cytopenias, you've got the blast, now you have to have the sequencing data. So I think that the take-home message of clinical trials for a TP53 mutated patient, 100%. And on top of it, if you don't know the mutation is there, you can't direct them correctly to the trials. So you got to get sequencing.
So, Guillermo, these are some of the trials that David brought up for a patient like this. Can you comment on, again, we'll get into more of the details, but sort of globally, some of the research avenues available. It seems like by looking at mutations, ISSM, you're upstaging a certain number of patients from lower to high risk. But once you get to the point where you feel, as in this case, that conventional options, HMA, aren't going to be effective, what are some of the strategies that are being looked at in trials?
That's actually a very interesting question, Neil, and thank you for having us. So right now, except for the last protocol, the SY1425, the first three, these are kind of agnostic of mutations. In other words, we're not really selecting out specific mutations to enroll, although the reality is that somehow the community has learned that potentially, and I want to emphasize this potential, that some drugs like maybe magrolimab, that is the drug being investigated on the ENHANCE trial, maybe is active in P53 mutated disease. I think it's something we could discuss later. I don't want to take too much time here. Right now, bottom line is that those three protocols, sabatolimab, magrolimab, the venetoclax, they are agnostic of mutations. I think that if the three of them were going to be successful and let's say at some point registered by the FDA, I think there will be probably a space from what we know in AML with venetoclax that, and maybe this knowledge of the P53, et cetera, that we could be targeting them in a specific fashion, meaning that maybe venetoclax could be favored in some particular molecular subsets, whereas magrolimab, sabatolimab in others. The last one is this retinoic acid kind of derivative that apparently only works or is targeted for this specific subset of patients with specific gene signature. So that's actually an example of targeted therapy. But the other three are agnostic. We will have to learn how to apply them in the future.
So, David, this is a slide I put together based on a bunch of review articles that I read about sort of the future of, and we have a lot of these in the slide deck, some of the issues and strategies we've already talked. These trials reflect the doublets and triplets that are being looked at. Any other comments on some of these other ideas about and whether or not they're going to be utilized in MDS? We talk about, looking at the goals of therapy and transplant eligible versus not transplant eligible, integration of molecular response, MRD status, maybe using MRD for allogeneic stem cell transplant. Before we sort of jump into the nitty-gritty of what to do today, any thoughts, David, about any of these strategies of particular interest to you, and any thoughts about kind of globally where we're heading?
Yeah, maybe to jump into your last point that you're highlighting, sort of MRD. So MRD is technically, as of today, not a thing in MDS, but I do think it will be a thing in the very near future. This is not going to be by flow cytometry, which has been nicely validated in AML, but will be by serial high-depth sequencing. So there's several ways to do this. You can do molecular barcode NGS, duplex sequencing, others, but you can define down to at least 0.1% levels, if not much deeper than that, by serial sequencing. I think the challenging historically is who cares, right? If you have a therapy that doesn't lead to molecular clearance of mutations, you don't really need to reassess it. But I think with doublet therapies, we're not only seeing higher remissions, we're seeing higher level of clearance, we're seeing some favorable outcomes post-transplant. So my hope is that we can use clearance of NGS as a very important early biomarker to maybe predict which patients may do best. And even if we're comparing, different therapies, maybe ones that have best molecular remissions may translate to those ultimate outcomes. So I think really key biomarkers in trials, and ideally this will be used in clinical practice in the not distant future. Maybe just briefly, I think we're very excited. We really want to have a doublet, a new standard of care therapy, and then we can go to triplets. All of this will add a level of toxicity. Even with doublets can be very, very challenging. HMA venetoclax still is a significant challenge within the community from the cytopenias and maybe even increased in MDS patients. So if we're thinking about going to triplet, it's probably not triplet for life. It's probably some sort of intensive therapy and then getting them on something that they can tolerate it. And then maybe one major decision point being, is this a patient that can go to transplant or not? We know we can get to transplant with patients up to 75 that are fit. So we're going to get a lot more people there. Even in some of these doublets, we're getting up to 40% of patients to transplant, but you have to have them in the right condition. And there's a lot to think about. And I think a lot to collaborate between community and academia in that setting.
So, Guillermo, one of the things that I found fascinating about we talked about these doublets and triplets, and also, we're going to talk about the fact there are two agents right now in phase 3 trials in terms of combination, sabatolimab, the TIM3 inhibitor, as well as magrolimab, the anti-CD47. And I just want to spend a minute or two before, again, we sort of jump into the pragmatics of what we're doing today, because it's the first time I really realized that really with these two new strategies, they're basically checkpoint inhibitors, something that general oncologists are using every day, except instead of anti-PD-1 or PD-L1 or anti-CTLA-4, now you're talking about anti-TIM3 and anti-CD47. So a whole new world of checkpoint inhibitors from my point of view. I want to get your take on it. But before we get into that, just a comment that last week we were doing a program with Mark Pegram from Stanford on HER2-positive breast cancer. There's so much going on right now in HER2-positive breast cancer, TDXD, et cetera. And at the end of the teleconference, I said, well, we're doing this thing next week on MDS, and I saw this paper that he had in his CV on anti-CD47 in breast cancer with trastuzumab. I'm like, what's going on here? Is this coming into solid tumors? Here's what he said.
CD47 is the checkpoint for macrophage phagocytosis. Just like PD-1, PD-L1 is the checkpoint for cytotoxic T-cell lytic activity against tumor targets, CD47 is the checkpoint for macrophage phagocytosis, killing mechanisms of tumor targets. The native ligand for CD47 is called SIRP-alpha. So at Stanford, Irv Weissman and Ravi Majeti invented an anti-CD47 antibody, and they humanized the antibody. The first in human phase 1 studies in solid tumors was completed here at Stanford. There were anecdotal responders, even published in JCO. The first in human phase 1 study in acute myelogenous leukemia was done at Oxford in the UK. I was the medical director of that project at the time because there was nobody else at Stanford that didn't have a conflict of interest with the molecule, it seemed. So now we just published a paper in the Proceedings of the National Academy showing that trastuzumab and CD47 antibody magrolimab are actually synergistic both in cell-based assays against ADCC-resistant cell lines that were developed in my laboratory, and also in xenograft models of those same ADCC-resistant xenografts. The combination of CD47 antibody plus trastuzumab was synergistic. So now we would like to propose a phase 1b study of that combination in metastatic breast cancers, or maybe in HER2-positive metastatic solid tumors.
So Guillermo, not so much to talk about solid tumors, but just curious about your vision for the microenvironment in MDS and why we're looking at these immune strategies.
There's a story that precedes this, because there is some, believe it or not, there is some science actually that trigger this. So around 10 years ago or so, several groups, including people at Hopkins, people at MD Anderson, others, realized that if you treat MDS and AML cells with a hypomethylating agent, you actually enhance the presence of these molecules, like what he was talking about, CTLA-4, PD-1, etc. So that triggered first-generation trials with drugs like nivolumab, ipilimumab. We're actually putting together almost 100 patients that we treated here, and there are some responses actually in P53 mutated disease, but we can discuss that later. The reality is that there is toxicity with these compounds, and in AML, it didn't look like that exciting. But that opened the door for this kind of like second-generation immune therapies. So you mentioned the TIM3, that's sabatolimab, and then particularly, and David has been the pioneer of the CD47 in MDS and AML, this kind of like T-cell agnostic, but present in macrophages signals, this cartoon that I think you're showing now with the magrolimab, that is very interesting because, as this prior doctor was saying, this could be used in any disease because in principle, these macrophages are not part of the clone. That's at least the hypothesis. And the data that David and that original group in Oxford showed that now it's been tested in this very large phase 3 study is quite exciting. So there is a rationale why these hypomethylating agents could actually somehow synergize with these immunotherapeutics. It's just that the targets are different than your canonical, checkpoint inhibitors in melanoma and other diseases. So this is very exciting to us.
So, David, I usually can't get beyond pathways more complicated than this slide, but I really like it when people explain things to me verbally, actually. And I wonder if you could just talk a little bit about, again, your vision of the immune microenvironment in MDS and where, anti-CD47, phagocytosis, TIM3, et cetera. Any comments on how you visualize what's going on and how to approach it therapeutically?
Yeah, I mean, so I think as Guillermo mentioned, actually, so 47 is overexpressed on a lot of cancers. Now, the original work was predominantly done in AML, but it has been duplicated in numerous solid tumor models as well. Also, other hematologics such as multiple myeloma. I think it's a very intricate and complex. You can make it very straightforward, right? You're blocking a don't eat me signal. Cancer cells have increased eat me signals. And then that balance of pro eat me signal is really what matters. So agents that can increase the pro eat me signal really are what allows for synergism. So azacitidine can upregulate the pro eat me signal calreticulin, and that's really the preclinical, model that showed improved synergy. Actually, there's been nice triplet data by Dr. Konopleva at MD Anderson, now Roswell Park, showing that even with venetoclax, that could be further accentuated. So I think you're going to see a lot of novel combinations if they can sort of tip that balance. I think what we need to see, and this is really maybe a one big negative across the sort of IO portfolio, is we need these randomized trials, not only, of course, to prove that two drugs works better than one drug, but what's really occurring in the immune microenvironment in patients. Is there a change in macrophage phenotype? Are you really seeing this phagocytosis? What adaptive immune changes? Is there something unique in patients that get remission on combo versus single agent? So I think there's a ton of science that ideally is going to catch up. These combos have been in general well tolerated, not the bad immune-related toxicities from the traditional checkpoints, which actually have been worse in our patients to date in most studies. And again, we're just hoping that these phase 3s read out positive to where we can really, move the field forward more quickly.
You mentioned the immune-related issues that come up with the other checkpoint inhibitors, PD-1, anti-CTLA-4. Do you see anything in terms of sort of effects on normal immune function when you use anti-CD47? It's sort of comparable to the response to that you see with autoimmunity. Anything like that you see when you inhibit macrophages?
At least with 47 SIRP alpha inhibition, we've not really had immune-related toxicities, I would say whatsoever. With TIM3 or sabatolimab, there have been some, but mild, LFT, cases, significant transaminitis. But again, it's been overall quite rare, predominance grade 1 or 2. TIM3 of course, is a checkpoint on T cells. So it makes sense that you may see more traditional immune-related toxicities than with 47 SIRP alpha. But across both, especially 47 SIRP alpha, that has not really, been an issue. I think simultaneously, they have sort of dual mechanisms where they may potentially help eradicate the underlying LSCs. And so how much that is important versus the true, immune activation, I think that's a question that is not resolved as of today.
So interesting. At the end of the meeting, we're going to go through the existing data. There's many situations where phase 2 doesn't necessarily translate to phase 3. But now we're going to really use your cases as a way to get into some of the practical issues that come up today. And Gail, I'm going to ask you for some of your thoughts on particularly the ISSM and how we're classifying patients. But just for the audience, we mentioned that this program's in conjunction with SOHO, and there have been 2 excellent SOHO state-of-the-art papers that have come out reviewing MDS in the last 2 years. Really great graphics in the paper. We're not going to go through all that, but I highly recommend that you check out these review articles. Are really excellent. So Gail, maybe you can comment a little bit about your patient and then your thoughts about where we are today with the existing tools, the approved tools that we have and how we apply them. Maybe we can start out with your 55-year-old man.
Sure. So I can talk a little bit about this patient. I think this patient, the reason I brought in this case is actually it kind of works well with a discussion that we just heard about a multimodality mechanism of action kind of concept for MDS. Because if MDS would be a one-hit, one pathobiology wonder, we wouldn't have to be talking about doublets and triplets and quadruplets. And this case might actually get to that. So you've got a CMML patient who's 55 with increased blast, normal cytogenetics, and a few mutations. And I can tell you that this patient was initially diagnosed during the course of a normal physical exam, which often happens, that people go in, there's a little bit of a something that gets repeated on a CBC, then it doesn't look right, then you're in the hematologist's office, and he was feeling fine and couldn't believe that we were talking about anything with the word leukemia in it. He got treated with what is now not completely novel, but a a commercially available oral decitabine cedazuridine formulation, which is a way to, it worked well actually during the height of the pandemic to get oral therapy and keep him out of the office. And actually it worked. And how do I say that it worked? Well, we had a complete remission by the standard definition of a complete remission. That's an hour right there to talk about morphologic complete remission and what that means and what it doesn't. But what it doesn't mean is that the disease is completely gone. What it does mean is that our transplanters were happy to take him because we got rid of the bad stuff, including blasts, still had detectable mutational abnormalities, but those don't usually totally go away. He had a haplocord stem cell transplant. He went through some nasty stuff, as is common during transplant, but came out again in complete remission. And unfortunately, just relapsed in July 2022. And you can see here that I used this is actually a regimen piloted at MD Anderson using a combination of intensive chemotherapies combined with venetoclax designed for AML patients, which I used here. And actually it worked and he's back in remission. But I think the important part about this case is a bunch. CMML is a nasty disease. Oral decitabine cedazuridine is a good drug for some patients and works well. But it gets back to the original point of, first of all, transplant doesn't cure everybody in MDS. And secondly, that if we really understood what was going on in this disease, why do I have a relapse and a transformation after what I think my colleagues would think that I did an okay job getting him through good therapy, but I'll let you toss it to them to see what they might have done differently. My point is that the microenvironment in MDS is not something we understand completely. This is, if you do a diagram of pathology of MDS, there are lots of arrows. And the point is, when you're talking about drugs, whether they're checkpoint inhibitors or combined with HMA or combined with chemotherapy or combined with whatever you want, we still seem to be missing some fundamentals about what's residual in the disease, even when by our current testing, the patient is responding.
Guillermo, any thoughts?
No, I totally agree with Gail. And, the treatment is immaculate. So patient goes into beautiful complete remission, is transplanted, and now it's coming back. And the question is why. And what I think is more perplexing from this particular case is that, and we see this unfortunately frequently, but what I think why Gail is showing this, in addition to everything she said, is, if you had like a complex karyotype, P53 mutation, etc., I say, okay, fine. But, it's diploid, if I remember, okay, has some kind of not that bad mutations. And despite that, he still relapses. I agree with her that, the microenvironment is very important, but it's also, I think, the cell of origin of this disease. So a few years ago, my collaborator here, Simona Cola, had a paper in Cancer Cell where she really tried to go deep, trying to find a normal stem cell in different models of this disease, and she couldn't. So as opposed to AML, where I think many cases, at least the ones that we cure, are patients that I call, it's a disease more of progenitors. So maybe there's a pool of normal stem cells that is still there. Unfortunately, in some of these patients, that's not the case. And I think, in a way, that's a little bit of a negative message, because the question is, can you cure someone like that if you cannot really eradicate the ultimate clone? That's tough. And I think that, David was alluding to this. It's like, how do we determine what is MRD is really critical here. And perhaps the message is, and I would not have maintained this patient after transplant with these features, but if we had some better tools to assess what happens around the time of transplant, maybe this more aggressive use of post-transplant maintenance therapy or some type of initiative around that could delay transplant will be important to consider at some point.
So I have in my mind my top 10 list of questions that I hear from oncologists. And David, a lot of them have to do with classification, particularly the ISSM classification that just came out and was published just a couple of months ago. Gail was mentioning that getting even patients asking about this. One of the things I think here is some of the mutations and what they mean. We talked about TP53 a little bit. Any other comments on some of the other mutations, David, including you see IDH1 and IDH2 there? I mean, is anti-IDH therapy or IDH inhibitors with FLT3 on the table? Any comments on where ISSM and where mutations fit in the paradigm, David?
Yeah, I mean, maybe very briefly on targeted. I think, unfortunately, targeted mutations are very, very rare in MDS. So, for example, if you take IDH1, it's only 2%, of MDS patients, and NPM1 is 1%, FLT3 is almost not, almost doesn't occur. So there are patients there. And actually, if you look at, for example, the IDH1/2 data, responses, if anything, are better and like from an overall response rate. Gail's had the elderly, frontline, IVO. So I think if we use these agents earlier, I have a couple anecdotal cases of severe neutropenia. I've used it in low-risk patients. I have one patient, 3.5 years, normal counts within 2 weeks, who had severe infectious complications before. So the answer is definitely yes. It's really hard for us to get these drugs approved because these patients are extremely rare. We add a couple patients per year to the front line or to the ivosidenib, abstract. So, but I'm hoping that they will be. I think, otherwise it's really impacting prognosis, a lot. We've always known SF3B1 good, P53 bad. I'm not sure what with all of this stuff in the middle. This online calculator that Gail, mentioned is very user friendly. It both includes the total number of mutations as well as all the mutations that have really been associated with adverse prognosis. And you'll get a much more personalized report for this patient. I think the challenge is, what does that mean clinically? We still have a long ways to go, and there's a lot of unanswered questions. I'll maybe turn it over to Gail to get some of her thoughts as well.
Before you do, Gail, I just want to bring up the issue of lower risk MDS. Each one of you put in a case, and you can check these out in the slide set of lower risk patients with SF3B1 mutations, ring sideroblast who got luspatercept. First, this case from you, David. Then, Gail, you have a very similar case. Another patient goes on luspatercept. And then, Guillermo, you put together this case here based on an 82-year-old woman. Can you talk about what happened with her?
Yeah, so I think this case, that is a real case, kind of, it's not that all this happened at MD Anderson, but it happened between the referral center and us, tells you a little bit of kind of the journey of someone like this. So elderly patient comes with symptomatic anemia. Actually, Neil, I was surprised that you were asking me about this issue. How can you be transfusion independent and still be symptomatic? I mean, that's an important point of discussion, but this actually happens quite frequently and has gotten worse with COVID and restrictions in terms of availability to transfuse these patients. You do your usual studies. Believe it or not, actually, I see this frequently where people forget that, you may have colon cancer or a bleeding polyp or something like this that could explain anemia in this context. And I'm happy that I saved quite a bit of patients by detecting earlier stage colon cancer more than curing MDS. So that's interesting. And you do your workup, etc. And then you do your bone marrow exam, and then you come with this entity, this ring sideroblastic anemia. You get this NGS panel that, at least at MD Anderson, we get on everybody, and has this particular mutation called SF3B1 that David was saying that is a good prognostic one, but it's also associated with this particular phenotype of the disease that is this refractory anemia with ring sideroblast. And most of these patients in the low-risk context, they have normal chromosomes. So you do your EPO level, and it's high. Another question is what you do. And you have a menu of things that you could do. The standard of care will be to start on an ESA. But the reality actually is that the label of luspatercept that is approved or registered for patients with this particular disease allows patients that are not quote-unquote candidates for an ESA because the EPO level is high. So, your options could be an ESA, or you could go directly to luspatercept. It's actually not widely understood. Patient has normal platelets. Some people will ask, why not lenalidomide? And then I don't think that will be given a hypomethylating agent there. So the patient actually got an ESA at home. And then after 3 months of use, the patient remains quite symptomatic and now is becoming transfusion dependent. And this is another key question that I see in the community, and I will be interested to see what happens actually in New York more than in Florida. That is, what is the duration of therapy with these ESAs? Because we see these people a year on therapy that never had really a response, but of course they tolerate the drug well, but they keep going. So that's something that as we learn how to use luspatercept, or maybe with this new frontline commands trial, maybe in change. So this could be for discussion. People will maybe optimize the dose of the ESA, like increase it, give it more frequently, change to different type of erythropoietin type of agent, or switch to luspatercept and this menu. But then, here the patient had total label for this drug, so we're giving something that is totally indicated. You switch to this relatively new compound, like a couple of years old. But still, I think we're still learning how to do this. But the patient actually is still, becomes transfusion independent, but marginally is still quite symptomatic. And that's something that is also discussed all the time, because occasionally some of these patients that are responding to luspatercept may have a little bit of this fatigue that you don't understand. They have like 10 grams of hemoglobin, but they are tired. So we could discuss this also with David and Gail. But here probably we felt that the hemoglobin was still low, even if it was becoming transfusion dependent. And there is this algorithm of those increments of this luspatercept that the community is actually not very familiar, where you start at 1.33, 1.75, before you jump into some of these other drugs that we have there, like the lenalidomide or the HMA.
So, and I guess at this point, the patient is doing well. David,
so
any thoughts about this?
To the 1 point,
right.
Sorry, Neil. So you increase the dose, and then here we achieve a situation where now the patient is feeling a little bit better with higher levels of hemoglobin.
So, David, any comments about this case and your experience with luspatercept and this situation? One of the most common questions we get about MDS is, when do you stop luspatercept? Particularly, when do you decide when people are not responding? But also, if they are responding, when do you hold it? Any thoughts, David?
Yes, I mean, Guillermo, I think, touched on a number of those. Actually, we have a very large sort of real-world data that we'll have for ASH, and then some other combinations that you can potentially do. So the dose optimization is key. I mean, every 2 doses you go up. If you get to 1.75 and you have no response after a couple of injections, it's not going to work. I think there are considerations of adding on ESA, that there are some trials that have started to look at that, and we'll have some data in the near future. But if you get a patient that has a real response, you keep it going. I think the one key thing is there's all these crazy cutoffs. You have to hold it, not hold it. If I have a patient 11 and a half and they feel great, I'm going to just keep it going on schedule. Yeah, if the patient flies up to 15, which I have had a couple of patients, I have had, holding doses and potentially adjusting it. But a lot of them, if you hold too much, you get this yo-yo and they feel horrible on the yo-yo. So these are, arbitrary rules. If your patient's feeling well at a certain hemoglobin threshold, try to keep them there, titrate up quickly. But if you get through it and you're no response, I mean, I have some patients, they've been on it for a year and a half. I would have stopped it after 3 or 4 months because it wasn't working in that scenario.
So, Guillermo, any thoughts about luspatercept, about this case? And also
so I think
this. Go ahead.
I think I agree with everything David said. This drug we're learning. And I think the indication from the medalist trial, that is what we have right now, it was a very good first step. But David said something very important, that sometimes these patients can go up to 15 grams, things like that. And we saw that with a prior compound called sotatercept, similar to this, where we were treating kind of earlier stage patients, and Rami, David, and I saw this, where these patients will go up and then we had to stop because the way the studies were designed. But what I'm trying to say is that it is clear that those patients with a lower transfusion burden, they do much better with this compound. So I'm curious to see what's going to happen with the COMMANDS trial. This is a study that is ready to close, randomizing upfront transfusion-dependent luspatercept versus your traditional ESA. That's going to be potentially a really important study that may change how we treat anemia in these patients. So I hope it's positive. But for what we have right now, the message I was trying to give with the 3 months is that if you push these transfusions and these ESAs, and then 9 months later, this person is transfused once a week, you decide to do this very expensive drug called luspatercept, you're not helping anybody. So I think we need to really start thinking about, when do we use this compound? And I think actually in this kind of individuals, earlier probably will be more cost effective and actually more clinically effective, instead of using it in heavily transfusion dependent patients where this drug doesn't really work that well.
So I want to move on in a little bit to talk about new approaches, particularly venetoclax HMA, which of course we get tons of questions about. Gail, you mentioned earlier the issue of oral HMAs. You're referring in terms of the pandemic, but I think still people like to avoid coming into clinic. So maybe you can comment a little bit about where we are with oral azacitidine and decitabine. But first, before you get into that, Venue in the chat room has a patient with an SF3B1 mutation, ring center blast, EPO 700, who's not responding to luspatercept, presumably after ESA, any role for the combination, or what would you do in that situation, Gail?
Well, I mean, I think that this has come up in the beginning of the discussion that not all mutations are created equal. So one of the things to look at, and I'm not sure if you have more about the patient, but SF3B1, it depends who his or her friends are and what other mutations are there, what else is going on with the patient, is there, are there increased blasts, et cetera. I think in general, if you have a classic anemia only patient in that scenario, sometimes, the old stuff of combination with GCSF and an ESA can actually work. That was what we were doing for a long time. We didn't do it as much in the United States because it's painful to get the drugs. In Nordic countries, they give a vial of each and say, go home. So I think that sometimes combination with GCSF can actually work for RARS patients. I haven't, there are combination trials going on with luspatercept and ESAs and combinations with lenalidomide also. I would be hesitant to kind of dabble too much in that, but it's not unreasonable. Lenalidomide does have single agent responses of about 24-25% in non-del5Q patients. So that is an option for an isolated anemia patient. But I would just encourage the writer to make sure that there isn't something else going on. Even consider another bone marrow biopsy if it looks like the neutrophils have now shifted, or if all of a sudden a few blasts are popping out. Make sure that the disease phenotype hasn't changed.
So do you want to comment on the issue of oral HMA? I kind of wonder whether or not it's, at least in terms of decitabine, whether it's underutilized or not. I'm not sure why people wouldn't want to use it, but you tell me, Gail, how do you think through the possibility of oral HMA?
Yeah, this is kind of the table that's not supposed to happen kind of thing. I guess I guess you get
right.
an F- in statistics.
Right,
if you
everybody always goes, I'm not supposed to do this, but.
Not supposed to do this, so here's the thing. I just a couple of comments about oral. So what we think is the case is that the oral decitabine cedazuridine is kind of a one-to-one swap for decitabine. It seems to be you do, the same kind of thing over 5 days. I will say that in general, just because it's oral doesn't absolutely mean that it's easier. Sometimes I think docs are feeling like they might be seeing actually some additional myelosuppression associated with the oral versus the IV, and certainly even if that's not the case, I never give an antiemetic ever with IV decitabine, and yet there are some GI issues with the oral. That said, it's a lot easier. Patients don't have to come in. They love not getting an IV. The oral AZA is a different story. So that isn't a one-to-one swap in the same kind of way. That's a whole different story. The oral azacitidine approval for AML maintenance is something that gets all mixed up with what you're giving to an MDS patient that you were just trying to give standard injectable azacitidine for 7 days, and then all of a sudden you're getting things like 14 or 21 or different schedules for oral azacitidine. So I would say that's more complicated. And I think Guillermo is nodding over there, sort of that you can't just sub in oral AZA for MDS in the same way. There are novel agents under development for oral azacitidine as well. Lots of clinical trials. I think we would all like all oral regimens all the time. But I have to say that sometimes it is a real pain for the patients to try to figure this out. If they have a pill box which has 12 different medications, including assorted antimicrobials, it's not so easy.
All right, let's move on. I want to hear what your thoughts are about venetoclax HMA, and that's definitely on our top 5 list of questions from oncologists and MDS. David, maybe we can get into this by hearing about your 76-year-old man.
Yeah, so I think this is just really highlighting a sort of transplant ineligible patient presenting with sort of prototypic pancytopenia, high risk MDS, 14% bone marrow myeloblast, and then has an NGS panel, has 2 adverse mutations, ASXL1, U2AF1, but the absence of a P53 mutation. Again, clearly this patient has indication for therapy. I did mention a little bit earlier that CR rates to single agent, or maybe I think I mentioned it earlier, to single agent HMA with ASXL1 mutation are very poor, actually as low as, less than 10%, 5% actually was really in our data subset. So of course, I would highly favor getting this patient on one of the trials that we mentioned earlier. We really need to move the needle and have new standard of care therapies. But because venetoclax is approved for AML, it is quite easy to get it off label. There are a couple of intricacies. It's given 14 days instead of sort of continuous. You still need to do a cycle 1 bone marrow biopsy. So all my patients get day 21 bone marrow biopsies as in this patient. And nearly all patients will not start cycle 2 at that day 28. They'll require a week or so break. Essentially, any of my patients that do blast clear, I drop them to 7 days. Immediately, and just kind of go from there. And if you don't do that modification, you may get blast clearance, but you're not going to help your patient because they're going to have severe cytopenias. And so the remission rates, and these have been presented by multiple people, Jacqueline Garcia at ASH, this past year, you have, response rates in the vast majority, and CR rates probably double of what we're used to with single agent azacitidine. And again, you have to tweak it, but even the durations of response and their survival in non-transplanted patients has looked good. The phase 3 Verona trial will help answer that question definitively, but I utilize it frequently in my RAEB patients if I can't get them on study.
Anything else you want to say about what happened with this man, particularly in terms of his counts?
It's just this is going to happen in almost every patient. Again, the key is you have to check a bone marrow, document blast clearance, hold therapy, think about adjustments early on. Many patients will actually have to adjust their HMA dose, so either to 5 days or some percentage, decrease. And really your goal is keep them with normal counts the whole time. If you're having severe grade 4 cytopenias, you need to do something about it because they're at danger of death and other significant, challenges, during that time. If you get fortunate at whatever level, counts are beautiful, keep it going. I think, do we need to keep it going for forever? Can we stop it? Right now, the standard paradigm is for forever, but maybe there's a subset of patients that get great clearance of mutations, and at some point we can stop. These are questions we have to answer. I would definitely not do that off study, but maybe with these doublets, we will get to move in that direction.
So I'm going to flip through some of the slides we put in the slide deck on venetoclax HMA, and you can check that out. But just curious, Guillermo, any comments about this case, about this strategy, and also this slide that David put together, bringing in the issue of goals of therapy in elderly patients like this one. Any comments, Guillermo?
I agree with everything David said. We actually just published a couple of days ago in Lancet Hematology, phase 1 trial of the azacitidine plus venetoclax, similar to the data presented by Jackie Garcia. This is like the big multicenter phase 1 trial. What we just published is the MD Anderson one, but the numbers are identical. So we have to wait for this Verona trial. So that's the phase 3 registration trial of AZA with or without venetoclax. It's similar to the Myelo study in AML. I think we all hope that this is a positive study because what we see is a higher rate of response. It appears that the duration of the responses are also longer, but until we don't see this in a phase 3 trial, we will not believe it. And as David was saying, this is going to take the care of this patient, a notch higher for all the reasons that he was saying. You have to marrow them more frequently. You have to use prophylactic antibiotics. You need to learn how to adjust the venetoclax in terms of whatever antifungal therapy you use and so forth. So the level of care increases, but I think this is going to hopefully improve the outcomes of our patients. But we need to wait for that slide that you're showing right now.
Gail, any comments or thoughts?
You allow me, the study just completed accrual, so we should really know the next, I don't know how long it's going to take. It's a survival trial, so, we need to wait for that to really come out.
It also brings up, Gail,
What's that?
I'm wondering where's the CR endpoint from Verona? So,
well,
right. So, Gail, any comments about venetoclax HMA, and also the issue of where does MDS-N and AML begin? You see the question of particularly people with blasts between 10 and 30%, how you approach those. Is there kind of a group that's in the middle that you could use either strategy with? Any thoughts, Gail?
Yeah, no, absolutely. And I think that so your second question first is, well, what's the difference between AML and MDS anyway? So right there is in the center of a giant fight that's going on between a couple of different classification schemes for MDS, exactly that point. And we've all had the patient who says, oh, thank God, 19% blast. Thank God I don't have leukemia. And we kind of sigh because we feel sad because in our minds it's the same disease. So I think, look, clinical trials is one thing. That's a whole different discussion. For a real life discussion, the question is, where are you going? Right? Where are you going with the patient? The response rate, let's say with an HMA and venetoclax, is higher. It just is. We already know that. But then what? So we don't know if your survival is better ultimately. We do know that you're going to be working a little harder to get to that response. And the question is, how do you maintain it? How do you stay there? And furthermore, do you actually know what you're doing with the venetoclax dosing if you have an antifungal on board? And which antifungal is it? And what dose of venetoclax are you using with fluconazole versus posaconazole versus am I using any of those drugs in an MDS patient? So I would say that if you are trying to get a patient who is coming out currently between 10 and 20% blast, whatever that number is by your laboratory, and you're thinking that you'd like that patient to have a complete response and go on to an allo stem cell transplant, there's at least room for consideration, with obviously the right answer always being a clinical trial, but the feasibility not always being there. If you can get venetoclax, there is certainly some rationale to consider it in a higher blast count patient who you're trying to send to a transplant. But with all due respect, in the same way that I wouldn't touch a bladder cancer patient without asking somebody who knew how to do it, I think it's a good time to crowdsource and call a friend to figure out how you're going to actually dose and get that patient through. Because if you've got an infection or a problem or something happening that's messing up the stem cell transplant, then you haven't actually helped. Conversely, if you have the 85-year-old patient who's kind of puttering along and doing okay and maybe not even needing that many transfusions, do you really have to hit that hard with an HMA Ven doublet to get a complete remission if they weren't looking that bad and if the transfusions weren't that bad and things weren't, do you really have to go in with a sledgehammer at that point if you're not exactly sure that, or if you're really not thinking that an 85-year-old patient may be going on to a transplant? So I still think that even though we have these new tools, you've got to be thinking long-term end game for the patient. Where are you trying to get that patient ultimately?
So I want to get into some of the data on the checkpoint inhibitors that we were talking about initially, and then hopefully we maybe deal with a couple more practical issues. I guess just a reminder that all phase 2 studies do not necessarily translate into phase 3. There's a lot of excitement about pivonidistat. It seems like that kind of died at ASH with the negative phase 3 trial. But let's talk about these two exciting new agents and, practically speaking, what you're going to expect, what you're hoping for phase 3, and what the implications might be. Why don't we start out with this case, Guillermo? You're a 79-year-old man.
I think this, thank you, Neil, brings a lot of the comments that Gail and David were saying. So you get referred this person 79, that actually they are starting to look younger and younger, at least here for some reason. Maybe I'm getting older, but that's actually the reality. You marrow them, 13% blast, consistent with MDS because it has significant dysplasia, has a, complex karyotyping, not a P53 mutation, has a couple of common mutations, TET2D and NMT3A. And now this is the question, do you use standard of care? Azacitidine, decitabine, the oral decitabine. Some people may even think, should you induce someone like this age group with 7+3? So I just put it there. But, the consideration is a clinical trial. For sure, I could have added in these questions or in these answers, ASA, venetoclax. Before I continue on this, going back to the oral HMAs, one thing that we're ready to submit that we presented at ASH last year is this oral decitabine venetoclax. I mean, that total oral therapy could be something very important in the future. So I don't see actually oral decitabine as an entity itself. I think we're also thinking about very exciting oral combinations, but maybe that's for later. So, this patient is motivated, qualified for a clinical trial with azacitidine and magrolimab. And the point that I was trying to make here is, we still need to improve our outcomes. And second, magrolimab is not only a drug for P53 mutated disease, although this patient had complex karyotype. Now, you asked a question earlier, Neil, about immune toxicities. And maybe David can help me explain what I'm going to say in 1 second a little bit better. But although I agree that magrolimab doesn't really have your ITIS type of profile like we saw with Nivo-EP in the same patient population, it has some very specific and distinct toxicity. That is this severe anemia, severe kind of hemolytic anemia that you can see during the first cycle of therapy early on. You don't tend to see that with the second and third cycle, but somehow you see that earlier. The explanation I heard, and maybe we can ask David later, is that maybe aging red cells, are more prone to destruction from this particular compound. But whatever it is, you have to be careful when using this doublet in patients that are already anemic to start therapy, because the next day you may come with very severe, that could be actually potentially dangerous level of anemia. So we early on at this drug, working with David for a few years now, we saw a couple of patients with 4 or 5 grams of hemoglobin the day after. So you don't want to be there. There's a very easy way to actually control this, that is by transfusing them a little bit before you give the therapy and maybe bring this hemoglobin a little bit higher than the 7 grams hemoglobin that is now the threshold of transfusion in many centers. So that's the only toxicity, but this is an important one. And I don't know how you do this in New York or in Tampa. We tend to admit these patients actually the first few days of this therapy, monitor them a little bit carefully. And then, as I mentioned, there's these protocols in terms of transfusions and make sure that you don't incur in this kind of like severe anemia that you may see if you just do this outpatient and you don't really pay attention to the hemoglobin. So that is very important point, because this is a very powerful doublet. I would like to see this, as a positive study. And this will be the only wrinkle that community doctors will need to know. They will learn about this very quickly, but this will be very important for them to be familiarized.
And David, it's an interesting, I think, unique wrinkle. I'm not sure I've heard about this with another drug. We just did a program on ophthalmic complications of anti-cancer therapy. So it seems like you can see anything with some of the new drugs that are coming out. But this is a really interesting phenomena. And also, David, I think it actually led to a hold on trials earlier this year until it was sort of straightened out. But can you kind of go through your view of what happened and what we learned?
Yeah, so as far as the mechanism, so yes, one is the old red blood cells, and actually at ASCO, Stanford had a nice presentation. So when patients are chronically on magrolimab, actually the RBCs, the CD47 is pruned off of them, so they're really not susceptible for any patient that's on chronic therapy. And we actually are very careful that we keep patients on constant magrolimab, even if we have to hold azacitidine for some reason. So we don't let the body, don't let it get out of their body where we have to reprime them and things like that. I think assuming that we're positive we have it, this is like the biggest issue, and it is very not straightforward. So it causes some blood bank interference, kind of like daratumumab. You have to get your patient to 9.5, and unless your infusion center is open for 15 hours, this can be very challenging. So I see like a pre-day 1 transfusion. You give the magrolimab a 3 to 6 hour repeat check. And then realistically, if you have to re-give blood again, how are you going to do that in the community? And so will Medicare cover inpatient magrolimab? And then you also have to have the azacitidine. In general, the community can't give this because of cost, reimbursement issues. So we have to tackle this, because if OS ends up being positive, we have a new standard of care. We have to, but it's not easy. And I think we're going to have to really work together, community, academia, payers, all of this stuff to make this happen.
So
once you get through week 1, it's easy. Sorry.
Well, that sounds good to me, particularly the lack of quality of life issues. But David, could you comment a little bit on some of the data that you just presented at the ASCO meeting from this phase 1b study?
Yeah, so we heard the safety, so there's really no unique toxicity. Infusion-related reactions occur, but grade 3 is quite rare. Overall response rate, 75%. True complete remission rates, which is sort of its own hour discussion in the MDS circles, between 30 and 40%. Again, about double, what we're seeing with single agent HMA, pretty good durabilities of CR and sort of all of the other metrics at the same time. I think if you look at the next slide, I think what was, as impressive as anything is really the overall survival, or maybe it's a couple slides, from now. But I think we parsed it by P53 mutation status. So we have a lot of P53 mutants on this study. Very early, there was some hint of signal, and given the desperation and lack of anything else, a lot while this trial was ongoing, everybody tries to put their P53 mutant patients. So we had a median survival of 16 months. Prospective trials have not had anything greater than 12 in any study, small or large. So I like that. And then if you look at the wild type patients, about 60% of patients were alive at data cutoff, and then 80% of people transplanted were alive at 2 years. So single arm study, pretty large, 95 patients, good safety data, encouraging response rates. We're all a little afraid from pevonedistat. Nobody can beat a true CR rate of 32% if that's what azacitidine control arm gets us. But I think the one big comment, at least in the 3 pivotal phase 3s ongoing, these are double-blind, placebo-controlled trials powered for one disease. And so I'm hoping that will then get us over the hurdle and actually have positive doublets and that we've learned from, unfortunately, a lot of mistakes in the past.
So that waterfall plot is really interesting, particularly with the TP53 added in there. I guess there was also this poster from the last ASCO meeting talking about the enhanced study that we've been referring to. You can read about the trial there. We talked about the hold earlier this year. This was a poster, again, you can check it out from ASCO, looking at the issue of anemia or red blood cells and hemolysis, et cetera, that David was just talking about. Guillermo, what about sabatolimab? Where are we with that, particularly in terms of efficacy signals at this point, Guillermo?
Yeah, so this is interesting compound. As we discussed earlier, targets this TIM3, as opposed to Nivo, EP, the drug overall is very well tolerated in terms of inflammatory complications and so forth. But David mentioned, or you, I don't know exactly, 10 seconds ago, something important, that is the CR rate in high-risk MDS seems to be in flux. So it was 17%, and now we see the Panther trial is like 31%. So it's not clear that this compound really is associated as of yet with like increase in response rates. But what I think is still is very interesting to me and appealing, and if we learn from the other immune checkpoint inhibitors, hopefully true, is that the duration of responses seem to be actually prolonged in those patients. So this is something that is quite important, and I think it could be quite significant, potentially actually for a triplet, because this drug could be very easily combined with a doublet of ASA-BEN, I don't know, ASA-magro or HMA-magro combination, but for sure, with a combo with venetoclax and an HMA that are very potent, something like this, if it really make those responses last longer, this could actually be major. The question is, are we going to get there? So we're all kind of anxious to see what happens with some of these randomized studies that are happening. And so I think it's a little bit early. We're at the fence in terms of what the next step of this for this compound are going to be. Well tolerated, longer duration of response. We have used actually quite a lot of it. And finally, as all these checkpoints, we see this kind of thing that patients with adverse features, P53 mutations, may do a little bit better than expected as opposed to just single agent HMA. So I think the jury is still out with this particular compound.
And again, you can check the slide set for more some papers on sabatolimab. David, any thoughts about sabatolimab and where it's heading? And also any comments on mechanism of action, or your vision of how it actually works?
I mean, the mechanism is great. Again, whether or not this is happening in the bone marrow of our patients, I think is a key question. And it's really those durabilities of the responses. Even the P53 is a really small subset, but the duration of CR in their MDS is longer than any other combination. So there is a randomized phase 2, the Stimulus 1. I think we look forward to see those data. We don't expect response rates to be different, as Guillermo mentioned, but is there a hint? What is EFS versus OS? I'm more in the OS camps, and they did appropriately power their phase 3, for OS only. So I think the mechanism is great, but again, we have to prove that these combinations are better, and again, at least the right type of studies has been run. Yep.
So final question, I'm going to start with Gail in terms of where we're heading over the next 2-3 years with MDS. Any predictions about, and particularly from the clinical point of view, how it's going to impact docs in practice? Any thoughts, Gail?
Well, I'm just looking forward to the chaos of having more than one of the phase 3s hit, because that's where the fun really begins. We've all been worried about that. I think that would be a high-class problem. At the moment, I think that, Panther was chastening. I think we'd like to have all of these drugs and then mix and match. But at the moment, I think we'll take any of them. I think that what's going to happen in MDS is I think there will be a new doublet standard of care. I do think that there is going to be a substantial ability to use oral hypomethylators interchangeably. I think we're going to work that out and be able to do it. And I think everyone's going to benefit ultimately from, I don't know about the novel morphological classifications. I'm skeptical about those actually being helpful. I'm positive they'll be confusing. I'm not sure they'll be helpful. But I do think that IPSS-M is the new way to classify people. And I think that what's going to happen is we're going to identify more familial syndromes because we'll see mutations. We're going to get out the AML patients who we should treat separately, and we can probably prevent some of the overtreatment and undertreatment, prevent some of the extremes in MDS that are people that we can capture better.
Well, I can tell you one thing, and that is there's a lot more to talk about in MDS now than even 2 or 3 years ago. I mean, this is like a tasting menu here. We could have done this for 4 or 5 hours, I'm sure. But in any event, thanks so much, Guillermo, Gail, and David, for joining us today. Audience, thank you for attending. Be safe, stay well, and have a great night.